Good afternoon. Thanks very much for joining us today. My name is Elizabeth Button. I'm a Practice Liaison Officer with the Oxford-RCGP RSC, based here at the University of Oxford. And today I'm going to be talking about the RSV ComNet II study, which is looking at the burden of respiratory syncytial virus in young children under 5 in the community. I'm going to begin by introducing the Oxford-RCGP RSC network. I'll then be covering some of the practicalities with regards to the RSV study, which includes looking at some of the data trends for this season. All of this information is available on the RSV study webpage. And just to note, some practices have already signed up to this study, but we've had to make some changes to the workflow. So do please take a look, and I will be in touch shortly about updates. The Oxford-RCGP Research and Surveillance Centre has had an over 50-year collaboration with Public Health England, and in that time we've produced weekly disease surveillance report. Since the COVID pandemic started, our network of practices has nearly quadrupled in size. We're now a network of nearly 2,000 GP practices that are extracting data from primary care computer systems. We also have a number of practices that are involved in virology and serology sampling, and together that creates an incredibly rich source of data, which is hosted at the Clinical Informatics Digital Hub called ORCID at the University of Oxford. We're able to link that data with other sources, such as HES data, which is the hospital episode statistics, and CHESS, which is COVID-19 hospitalizations. The research that we do informs policy, for example, used in surveillance for Public Health England, for vaccine selection by the World Health Organization, and some of the research has also been presented at JCVI, which is the Joint Committee on Vaccination and Immunization. As well as our important data work, we're also looking to engage more broadly in research, which this study, the RSV study being cohort study, is a prime example of. So we know that RSV is associated with a high rate of illness in children aged under 5 years. It affects the lungs, and almost all children get it. Most cases are mild, but some do end up with serious complications. In terms of the aims of this study, it is to assess the clinical and socio-economic disease burden of RSV in young children, as well as their parents or guardians, and specifically to understand which children develop symptoms requiring further healthcare usage at primary care, hospital, or intensive care levels. This research will inform primary healthcare provision and contribute towards baseline data for RSV immunization strategies. Now, I think it's useful to visualize this study in two components. The first is a virology swabbing surveillance activities, followed by 2 short telephone interviews. And the questions that are included in those interviews are on a patient's medical history, their healthcare usage, and the impact of RSV on the quality of their life. It's worth noting that comparative studies are taking place in the Netherlands, Italy, as well as in Spain and Belgium. As I mentioned, this study really has 2 main components. The first, on day 1, is the virology surveillance and study approach. In this scenario, a child patient under 5 years of age would present with symptoms of acute respiratory illness, influenza-like illness, other RSV symptoms like bronchiolitis, runny nose, fever that is acute and within 10 days of symptom onset. The practice would then collect a nose and throat swab for surveillance and approach the parents or guardians about the RSV study and obtain informed consent. As is standard practice with our surveillance activities, the practice would need to enter in certain research codes about the swab having been taken, as well as RSV-specific research codes regarding consent into the patient's computerized medical record, whether that's EMIS or TPP, depending on the practice. Behind the scenes, the swab gets sent to a lab for testing, and the practice then receives that result and will need to inform the parent or guardian of the RSV result. The second component of the study are the 2 telephone interviews, which are conducted by practice staff with the parents or guardians of patients who have tested positive RSV. These short telephone interviews are conducted then at day 14 and day 30. Just some further details. As is the case with our regular virology surveillance, practices have the choice of 2 pathways for doing virology swabbing. They can either order in-practice kits using our material requests portal for swabbing at the practice. These kits can also be handed to patients to take home to self-swab. Practices can also sign up to receive weekly voucher codes, which they can then pass on to patients remotely for ordering kits to their home to self-swab at home. I won't go into too much detail. Details are provided on the virology and serology surveillance webpage. Do please take a look if you're not familiar with the virology swabbing. Consent for this study can be written or verbal in the case of a remote consultation, but do please record this on the parent-guardian consent form so that there is a paper trail. Practices will be expected to know how to take informed consent, but since this is a clinical trial, GCP training is not required. In terms of coding, I've already mentioned there are standard procedures for our surveillance swabbing, which includes recording that the swab has been taken as well as results. For the RSV study, there are some additional specific research codes, primarily that consent has been given by a parent or guardian, and that the CPMS, that's the Central Portfolio Management System, is included. Further instructions are available on the RSV study webpage. In terms of monitoring and data linkage, practices will need to update a very short data linkage form for study monitoring, which the study team will provide. So the 2 short telephone surveys, these will be done using an electronic form, which again will be provided by the study team. These surveys shouldn't take more than about 20 minutes to complete. In terms of a target, across the network, we're looking for 500 swab participants, regardless of RSV result. How this breaks down at a practice level really depends on how many practices join the study, but if we conservatively aim for around 50 practices in this study, then it will be around 10 swab patients per practice. In terms of a timeline, the current study has been agreed to the spring of 2021, though it's extremely likely that the study is going to be extended through the summer, if not the end of next year's winter season, 2021-2022. But I will circulate details once that's official. Speaking of timelines, I thought it would be interesting to take a look at some of the trends in the data for this season. What I've got here is a graph from one of our recent weekly disease surveillance reports, specifically looking at the virology swabbing. And what you have here at the bottom are the weeks of the year. The blue line represents the 5-year average for influenza-like illnesses, which you can see peaking around the end of December, beginning of January, those between weeks 51 and 2. Now, in a normal year, we would expect to see RSV to mirror the 5-year average. However, this year, we've hardly seen any RSV at all. It's only in recent weeks here circled in red where a few RSV cases have begun to emerge. Now, obviously, we think that this is due to lockdown, so the circulation of winter viruses has been low. And we suspect that with the easing of lockdown and greater school mixing that we'll start to see an increase in RSV. To an extent, this is something that we were anticipating. In Australia, we saw a summer surge of RSV cases, and we thought this might be mirrored in the Northern Hemisphere. What I've got here is a graph from the Centre for Disease Control in the US looking at urgent care visits for RSV among children under 5 years in Florida. And what we can see here is that in a typical year, lines in grey, you would expect those cases to spike in the late November, December, January months. However, this year, cases of RSV during those months was relatively low. It's only in recent weeks, in more the spring months, around the weeks 13 to 17, that Florida is now seeing a real surge in RSV cases. And we're having reports of RSV cases now also emerging in France and Iceland as well. In fact, back to some practicalities, practices will be able to reimburse for two types of costs. The first are research costs. These are invoices that can be sent to the study team based here at the University of Oxford. These include a one-off site setup cost, which includes training and monitoring, as well as virology swabs for surveillance, approaching parents or guardians about the study, as well as conducting those two follow-up interviews. Support costs can be invoiced to your local CRN and cover informed consent for the study as well as eligibility checks. It's just worth noting that the virology swabs form part of our surveillance collection, so will be reimbursed through our surveillance processes, and otherwise research costs will be paid at the end of the study. CRN costs, as I understand, may vary slightly based on your local CRN. So in terms of next steps, you must be an Oxford-RCGP RSC practice and be contributing towards virology surveillance. If you'd like to join the RSC or begin virology surveillance, do please get in touch with the practice inquiries email. For the RSV study, you will need to complete an RSV expression of interest form. This will be taken as you confirming capacity and capability for the study, and a member of the study team will be in touch about next steps. Again, for the RSV study, the next step will be to sign a GP site agreement. This is the agreement with the University of Oxford. You will also be sent an organisation information document complete, which is required by the NIHR. Once you are a virology surveillance practice, you can begin swabbing any eligible patient. But for the RSV study specifically, if there is one takeaway from this seminar, it is to please begin swabbing any eligible under 5-year-olds and to be on the lookout for RSV cases. After the surveillance swab, the next step is to approach parents or guardians about the RSV study and obtain consent, and importantly to code into the patient's clinical medical record and keep the data linkage form updated for study monitoring. I've made mention of lots of different documents, so I thought it would be useful just to summarize the key documents that are involved in this study. In terms of practice recruitment, practices need to complete the expression of interest form, the EOI. They then need to sign the GP site agreement and complete the OID, the Organisation Information Document. In terms of study implementation, we have patient information sheets available. Practices will need to complete a consent form as well as the 2 telephone surveys. For monitoring purposes, practices will need to keep up to date a very short data linkage form. For further information, we have a GP information sheet as well as the study protocol. Since the RSV ComNet II study has been adopted on the NIHR portfolio, the study is eligible for CRN support, and so practices will be contacted by their local CRN in the first instance with a research information sheet for practices, also known as a RISP. That just leaves me to say thank you very much for watching. If you do have any questions about the RSV study, please do email me directly on elizabeth.button@phc.ox.ac.uk. And otherwise, if you have any general queries or questions about surveillance, please do get in touch with the Practice Inquiries email, and a member of the Practice Liaison team will be in touch with you. Thanks very much.